Our speaker today is Dr. Erin Ferranti, and I'm very excited to introduce her to you. She is an Emory-grown scholar with her degrees from nursing, health policy, and she did her PhD in nursing here at Emory and her postdoctoral fellowship. Lots of connections with the School of Public Health and her work. Excuse me, this is one of those mornings of congestion. um, and also, in addition to her academic credentials, Dr. Ferrante is certified as a diabetes educator and also a lifestyle coach with the National Diabetes Prevention Program. And so her background fits really well with our center and some of the topics she's going to talk about today. She's had a number of awards for her scholarship and teaching, and was recognized by the Southeastern Primary Care Consortium and the AHEC Center for her service. She has Excellence in Leadership Awards. So she has quite a awarded set of accolades. And Erin was also, in addition to her academic career, she was the assistant chief nurse for the Georgia Department of Public Health and had a lot of input into the state emergency plan. In addition to serving as faculty in the School of Nursing and also with appointments in nutritional health sciences and the Department of obstetrics and gynecology in the School of Medicine, so 3 academic appointments. She also is the coordinator and director of the Farmworker Family Health Program, which is a multidisciplinary program with leadership from the School of Nursing and also involves public health and involves physical therapy and I think pharmacy from Mercer, right, Erin? So very exciting program to serve farm workers in South Georgia. And currently, Erin's work is funded by the NIH, NIDDK, and also NIH, NINR. She's just received an R01 funding, which is very exciting. She also has funding from the American Diabetes Association and the American Heart Association, as well as the Hercules Center. So she's got a lot going on, and we are grateful that she's taken the time today to share her work, cardiometabolic risk and resource connection in maternal health. So thank you, Erin, for being here.
Yeah, thank you, Sandy. And so many kudos go right back to you because Sandy's been my lifelong mentor. We've been working together since 1998. So really helped coach me on this journey. So very grateful for that. So yeah, this is my favorite topic to talk about. I had wanted to have more data to be able to share today. Don't have a lot of data, but can share a lot of things about what we're starting. So any of you in maternal health know that cardiovascular disease is a major issue in maternal health. It's the =1 cause of death for all US women. Sadly, though, women are not aware that they are at risk for cardiovascular disease. Only about 44% are aware that it is the leading cause. And surprisingly, I didn't realize this until I looked this up, that women with hypertension are actually less aware. And so these are a lot of the women that we're working with. Less than 50% of women have optimal preconception cardiovascular health. So women are coming into pregnancy already with cardiovascular disease and the risk factors that cause it. And then women who have type 2 diabetes have a higher risk factor burden. They have a higher relative risk of cardiovascular disease. They're less likely to receive risk reduction and guideline-based treatment. And then psychosocial risk factors have a stronger impact on both type 2 diabetes and cardiovascular disease risk for women as compared to men. And so if you're paying attention to the news, you know that there's a rise in maternal mortality, absolutely uncalled for. We, in the United States, have a rise as compared to other developed nations, which are not facing these challenges. So it's multifactorial, but this is just to show that we are definitely seeing a rise. And most of these cardiovascular maternal deaths or most of the pregnancy-related deaths are cardiovascular in nature. So this is US data, so up to 40% are cardiovascular related, and everywhere I have the heart is a death by a cardiovascular complication. And then when we look at who's most affected by race and then by age group, it makes sense that women older, 40 and older, are the ones more impacted. But when we look by race, it is non-Hispanic Black women who are suffering the most. And in Georgia, that is very true. And I'll share some of those statistics in just a minute. So we have tremendous disparities. What most people are surprised by is that most pregnancy-related deaths actually happen in the postpartum time period. So we think about pregnancy and delivery as a high-risk time point, but it's actually the postnatal time frame where we see the bulk of maternal deaths. And the deaths differ by cause depending on when they happen. So during pregnancy and delivery, it's more related to the acute delivery and hemorrhage and things like that. As we get into 43 days postpartum and up to 1 year, it's more likely to be cardiovascular disease. That was exacerbated by the pregnancy. And so when we look by region, the Southeast is doing particularly bad in maternal related deaths. So Georgia is part of that HHS Region 4, so the darker color indicates worse outcomes. We're not alone, but we are struggling in this region. And so up until recently, I sat on the Maternal Mortality Review Committee, and so they've been putting out a lot of reports recently and some recent reports. So this was the 2018-2020 executive summary. So here in Georgia, during that time, we had 30.2 pregnancy-related deaths. The leading causes were hemorrhage, mental health, cardiomyopathy, cardiovascular, coronary conditions, embolism, preeclampsia, and eclampsia, so bulk being cardiovascular. And the MMRC agreed that nearly 90% had some chance of being prevented. So these are preventable deaths. And many of the women were insured by Medicaid at the time of delivery. So again, looking very Georgia specific, I shared with you the US data, but looking very Georgia specific, the bulk of maternal mortality is related to these cardiovascular conditions, highlighted there in red at the top. And then at the bottom, looking by when does this happen? And so the bulk of it is happening 8 to 60 days postpartum. So, up to 3 months postpartum, but again, the bulk of it is in the postpartum timeframe up to 1 year. Hence the reason for all of us advocating for Medicaid extension and care coordination in the postnatal timeframe. And, there's a lot of policy work going on in that arena, which I'm not going to share today, but, those statistics are what's driving that work. When we look at maternal morbidity here in Georgia, it is, again, cardiovascular conditions that are driving this. So looking at, so in orange represents non-Hispanic Black women. In blue is non-Hispanic white women. And you can see, just broken out by maternal age. Of course, we see it higher in older women and then by insurance payment. But then looking at the 3 graphs on the bottom, it's diabetes, hypertension, gestational hypertension and pre-pregnancy hypertension, which are driving the morbidity. So again, these are women coming into pregnancy already at risk. And so these are data from the MMRC highlighting the specific deaths by cardiomyopathy. There were 13 of them. And the reason I bring these up is because this is my area, of course, but to highlight that all were considered to be preventable. Contributing factors, most were in the postpartum timeframe. Contributing factors were bias and discrimination and obesity. And then things that could have potentially prevented it were some things that were certainly modifiable. So one of them being patients and families lacked understanding. Very similar with cardiovascular and coronary conditions. Again, the bulk was in the postpartum time period. We agreed that 100% of those deaths were preventable. Obesity contributed to it. Other things that contributed were lack of case management and case coordination. We're not doing a good job of following women in the immediate postpartum. And then again, for women with preeclampsia and eclampsia, the bulk, again, were in postpartum, 100% preventable. Obesity was a contributing factor. And then again, patients lacked knowledge. There was lack of care coordination. So we're really missing this opportunity in the postnatal timeframe to make a difference. We do a wonderful, and I've said this for all the years that I've worked in maternal health, we do an amazing job taking care of the pregnant woman because we want to make sure that that baby is safe and is delivered, well with minimal complications. And we do a great job with pediatric care, and moms, really focus on getting that baby in for infant care. What we do a terrible job of, and I can say this as a provider myself, is that postnatal follow-up and care of the woman in the postnatal time frame. And the data show that. So overall, a summary of those findings is that the maternal, the cardiovascular deaths are in the postpartum time period, 100% are preventable. Obesity, we know, is a significant contributor. Lack of care coordination, lack of awareness by patient and family members. So these are all modifiable. And as a nurse, when I look at these things, I'm like, we can have an impact here. This is where we can make a difference. And so that's what we're trying to do. And so this was a scientific statement put out by the American Heart Association recently, looking at opportunities in the postpartum time period to reduce cardiovascular disease after adverse pregnancy outcomes. And what I highlight here in red are the areas that I've been thinking, like, this is where we can make a difference as providers, as nurses. So home visitation and community health worker programs, I'm going to talk about one of the grants that we have on that. And I know my community health workers are on the call, so thank you for being here. The national DPP, so I'm a diabetes coach and I've worked with postnatal women. There's opportunity there. Group exercise weight loss programs, especially when obesity is driving this. Health coaching, group weight loss programs, again, needed. Postpartum care clinic, I put that in green. I'm not actively involved in that anymore, but I don't know if Suchi's on the call. Dr. Suchi, maternal fetal medicine specialist, is running a postnatal clinic, and we were in the early conversations with that. So love seeing that, love seeing the rise in cardio OB programs and care coordination in the postnatal timeframe. So that's really needed, and we are doing that here at Emory. And then AHA Life's Essential 8. So these are the individual behaviors and risk factors to focus on to ensure good cardiovascular health. So I highlight those in red because those are the things that we're really trying to focus on. So Life's Essential 8 came out more, it used to be Life Simple 7, it's now Life's Essential 8. We added sleep as a factor of one of the things that we need to pay attention. We know the importance of sleep in relation to cardiometabolic disease and what happens when you don't sleep well. So eating better, being physically active, quitting tobacco, getting healthy sleep, managing weight, cholesterol, blood sugar, and blood pressure. All these things contribute to good cardiovascular health. Nothing surprising here. What I really love about the AHA's Life's Essential 8 is that they talk about all these individual risk factors, but they embed it with the understanding that social determinants of health and psychological health are really driving this. So you can, and I know this in working with patients and participants, you can tell women all day long to eat healthy, but if they don't have access to a grocery store, if they don't have transportation, if McDonald's costs $1.99 versus a bushel of apples that costs $5.99, it's very clear what the choices are going to be. And so if you don't address the social determinants of health and psychological health, we're not going to make any impact on these individual factors. And we know health education alone does not equal health behavior change. And I think it's why, we're really struggling with the cardiometabolic disease that we have in our population. It's very hard to be healthy in this country. And so I was, back in 2014, 15, somewhere around there, I was funded with a Birch grant, which I'm so grateful to the Birch program. It's for women's health. And it was able to launch what I wanted to do, which was really focus on the postnatal timeframe. I had wanted to do that forever. So as I was doing my Birch study, I was following women in the postnatal timeframe, and a lot of women needed home visits because it was hard for them to come in. When you're a mom with children, it's really hard to come in for a research visit. So as a public health nurse, I was like, sure, I'll go do home visits. So did home visits, and a lot of the women felt very isolated. So anecdotally, they were telling me, it'd be so great if we could connect with other women in the program or other women who are doing the study. And so I just kept registering those comments, and I was like, okay, yeah, that would be great. We should do stuff together. And so as I was thinking about that and, what more could we do? And that was just a descriptive study. We weren't doing any interventions. But looking at, what could we do in the postnatal timeframe that would support women? And so looking at some peer support, coaching, because I was doing diabetes coaching at the time. So got into the literature and looked at where the evidence base was for this. And so in working with health disparities, there's a lot of focus on all the negatives, like how can we fix the negative things? But in working with Black women, there's evidence to suggest that having an asset-focused approach is more beneficial. And so really focusing on the strengths and assets. We have seen that peer support has been effective in postpartum weight loss, in breastfeeding, and in mental health. And it is effective in cardiovascular risk reduction, but it was always done in older women. And that's the thing I've always said about pregnancy, is that it's an opportune time to really identify cardiovascular disease in a younger population, where we traditionally looked at cardiovascular disease in women ages 50 and 60 and up. But, we know that women who have gestational hypertension will develop chronic hypertension within 5 to 10 years of delivery. And so we need to be focusing in this younger population. So there wasn't a lot of evidence to suggest that peer support would be helpful for cardiovascular risk reduction in younger women. So I said, well, let's try. And so American Heart has an area where they focus specifically on women's heart health. It's Research Goes Red. And so they put out a grant call to really focus on social determinants of health and mitigating the risk of hypertension. They have this national database where women can enroll in the national studies that American Heart has, and it becomes this like national platform. What AHA was struggling with was getting younger women to enroll. So, again, we're all biased thinking cardiovascular disease happens in older women. And so they were really looking for ways, how can we get younger and more diversity in this national, AHA research database. So they put out these calls, and they really wanted the funded projects to look at social determinants of health and mitigating hypertension. So we got that first grant in 2022 to basically, kind of leading up to it, run peer support groups, connect women to resources in the postnatal timeframe to try and mitigate hypertension in that, as they progress out of postpartum. And then we just got another supplement, which is current right now, to just continue that work. So we're right smack in the middle of it. And so I work closely with Ann Dunlop. I don't know if she's able to be on the call today. Ann is my very close mentor. And so when that very first prenatal cohort was established here at Emory, which was the one that looked at microbiome and the incidence of preterm birth related to oral, vaginal, and gut microbiome, I was a postdoc at that time. So I worked on that study and have been mentored by Dr. Dunlop ever since. And so that is over 700 women now in that prenatal cohort. And then my Birch and K studies followed women into the postnatal timeframe. So I have that postnatal participant group. And then there's another ECHO study, which, working with Ann, that's following the children of the mothers that we recruited during the prenatal. So that's the group of women that we're recruiting from the AHA study. Our goal is to get up to 150. It's a crossover, pragmatic, randomized control trial to test community resource navigation with and without peer support. We run 6 monthly peer support groups on Zoom. Pros and cons of that. I'll share more about that as we go on. The goal really is not health education, because like I said, health education really doesn't determine behavior change, but we did find, women are seeking knowledge. They want to know more. They want to know more about these Life Essential 8. So we design each one around one of the Life Essential 8. And then as issues come up, if women are, citing that they're having food insecurity or transportation issues, we really dig deep into those issues and try and connect women to where they can access resources. And what the goal is to really have women support women. We're certainly not the experts. We're health coaches, we're running these, but we really want women, who are of similar background and in similar, childbearing years to share with each other. And that's just been a beautiful thing to watch. I love being on the peer support groups and seeing women connect that way. And so the outcomes that we're looking to improve perceived stress and social support. We're looking to decrease health-related social needs. And of course, we are looking at clinical cardiovascular risk factors. So we measure at baseline, 6 months and 12 months. The reason why it's a crossover is we didn't want to deny any woman the opportunity to be part of the peer support groups. So if they're randomized to being an early intervention, they come right into the monthly groups. If they randomize into the late intervention, they'll spend 6 months, just doing regular care. And then they have the option to join the peer support groups at the second 6 months. And most of them are choosing to join. So I guess that's a testament to it being something that they were interested in. I mean, they were the ones who told me they wanted to connect. So some preliminary data. I have a soon-to-be PhD student. She's coming into the PhD program who just wrote an abstract. We're waiting to see if it gets accepted, but we have 52 women enrolled so far. We got a very slow start. I won't go into the details of why, but AHA was switching vendors for their national database, and we had a year delay getting started. So it was really stressful. So anyway, of our goal target of 150, we have 52, so not bad. Our women are 33, roughly mean age, and they really do have some major social needs. So this is just baseline data. We haven't separated out, we just finished our first round of peer support groups. But 35% are worried about food not lasting. 25% have transportation insecurity. We see that because when we bring them in for their clinical visits, we have to typically use Uber. Financial strain, right? Who isn't struggling with financial strain? This one surprised me, the feeling lonely and isolated. I didn't realize that this would be so high. So to actually see this, in percentage, I was like, okay, yeah, no wonder they're asking for, connection. And then there's some real concerns about their personal safety in terms of physical harm from family and friends. This hasn't come up. Well, I lied. It came up in one peer support group, so we talked through that. But the transportation, food, financial strain, those issues come up a lot in the peer support groups. Healthy eating, how to get their kids to eat healthy. Those are a lot of things that we do talk about. So I guess I'll leave questions for the end because I'm kind of flying through this, which I tend to do. But so the AHA study has been great. They're putting out another supplement for those of us that are already Research Goes Red awardees to do more with the national database. So I'll be applying for that May 1st to keep up this work. As Sandy mentioned in the introduction, the other hat I wear is that I direct the Farmworker Family Health Program, which is a clinical program in its 32nd year. This speaks to my public health roots, and I love doing this work. I've been directing it for the past 6 years. And so there's two farm worker programs. You probably know the one out of the PA school, out of the School of Medicine, run by Jody Guest, and then ours out of the School of Nursing. We work in Colquitt County. We provide primary care to migrant farm workers and their children. What has bothered me about, it's amazing work, but as a women's health researcher, one thing I noticed is that we were not providing care to women because there was children in the schools that we saw during the day and men coming in from the fields at night who are that's just how our clinic was set up. The women are working overnight, packing up the fruits and vegetables. And so they're sleeping during the day. And then as the vegetables come in at night, they're working in the packing sheds. And so it was really hard to access women. And so it's just been bothering me, like, how can we do this better? And so we have a HRSA grant that was funded about 3 years ago, which is aimed to get students more involved in mobile care. So when you think about rural health and the access issues, the maternal health access issues, there are tons. So this HRSA grant enabled us to buy a van, but the Ellington Clinic, who is our clinical partner down in Ellington, Georgia, who is the medical home for farm workers in Colquitt County and the surrounding area, I wanted them to own it so that they could have it full outright. But it is state of the art. It has 2 exam rooms. It's the bigger one right there in that picture. And so now they go out and do outreach. We send students down to train. And so that's been great. I share all this to say is I've been wanting to build our program of research in the farm worker program ever since I took over directing and, thinking about women's health and maternal health. And so building on the AHA project, there was a great opportunity with NIH that put a special call out on rural health and really wanted to focus on migrant health in particular. And so we applied and we got it. So it's my first R01 and we got it on the first try. So we're so grateful. We just got funding in September. So we're really just in the beginning stages of getting launched. My Spanish is terrible, so I'm not going to embarrass myself by even saying the title of our grant, but you can read it. And it means the heart of women. And those are our partners. So Dr. Ursula Kelly is my MPI. Lisa Cano is right there Teresa is in the pink. Courtney, who owns Southern Valley Farms. So Southern Valley Farms is a female-owned farm, family farm. It's one of the largest in Southeast Georgia. And she's so excited to be working with us, myself. And then Lisa. So Lisa and Teresa, if you can't tell, are twin sisters, identical. And they were working in our farm worker program for many, many years. and left the clinic. And when we wrote this grant, we wrote the community health worker job specifically for them. So we're so excited to have them on the team. And so, as I was saying, farm worker women are underserviced in the program. They're understudied in research. They're very hard to find. They have really high rates of cardiometabolic morbidity and maternal morbidity. They don't have high rates of maternal mortality, which is what they're different from non-Hispanic Black women, but do have really high rates of morbidity. So obesity is really challenging. They have really high rates of type 2 diabetes and gestational diabetes, and then high levels of isolation and stress. And now in this political climate, a whole another level of stress. And so we are anticipating a lot with that. So basically, we took our AHA study and, modified it for our farm worker women. So this will be in person as opposed to doing it on Zoom. A lot of the women live in community or at least live very close to each other. It'll still be peer support intervention. We're aiming to recruit 250 women. And these are H2A workers who are here about 11 months out of the year. So, we have to struggle with that time period. And this is not specifically on postpartum women. This is really thinking about women's health and trying to get women as healthy as they can be before entering pregnancy. So my focus has always been in the postnatal timeframe, but we're too late when we get there. We really need women in optimal cardiovascular health before getting pregnant. So we're taking all comers in this. So we're looking to reduce psychological health challenges, improve social well-being, deal with social determinants of health, again, with the immigration issues and the stress. And you can imagine being a new immigrant here where you don't speak the language, you may have been trafficked, how to navigate healthcare and navigate anything is really challenging. And so we're really started. Our goal is to start March 1. We're in the middle of getting IRB and all that and doing all of our trainings, but the women start coming into the country around March 1. And so it really amps up in March and goes through December. And so this is just our conceptual framework. Again, like I explained with our American Heart grant, we really are focusing on social determinants of health and psychological well-being as the underpinning to improve cardiovascular health. You can't, do the healthy behaviors unless you have the other things managed. So we're going to do the same thing. They'll have an opportunity to be in the peer support. They'll have the opportunity to be in the second phase of it. If they don't get randomized the first time, we don't want any woman to miss out if they want to be part of it. We're anticipating 60 to 75 minutes of in-person peer support. We do an hour on Zoom. And, we're hoping to bring food and do all that. So our goal is to start in a month. And so this is our team, our full team. Celebrating right around Christmas. And then another area of research for me is, and this is new for me, partnering with Dr. Doug Walker, and it's where the Diabetes Center has funded some of this work. So looking at the exposome in maternal health. So one of the things, we run a prenatal clinic in the Ellington Clinic. They have about a 20% rate of gestational diabetes. When you look at the general population, it's anywhere from 7 to 10%. So it's about double in our Mexican immigrant women. And there's no good reason why. Obesity contributes to some of that. Certainly genetics contribute to some of that, but compared to other Mexican women, they're double. And so we're trying to understand what is contributing to that. We know pesticides are related to cardiometabolic disease. It's been looked at in men. It hasn't been looked at in women. Certainly hasn't been looked at in pregnant women. So we're really excited that the diabetes pilot will be focusing on that. Also, like I said, all these studies hit at the same time, so we're amping up all 4 of them. It's a little stressful, but wonderful. Great problem to have. So we're looking at the pesticide exposome and perturbed glucose pathways and the incidence of gestational diabetes in our pregnant moms. So we'll be working with Ellington Clinic to enroll women. Our goal is to enroll 60 women. And we're in that current year cycle right now. And then with the Hercules, so the diabetes is with our farm worker women. The Hercules pilot is with our African-American cohort. We're looking at our stored samples there. So looking at prenatal and postnatal stored samples and just doing an untargeted serum exposome look. We know that beauty products, all the things that we're exposed to. And so the big goal is to have a health education campaign that's very tailored. We won't be doing one-on-one like this was your toxicant exposure, but to look at it as a group and be able to, so I have a couple students working with me, and as soon as we have the findings, we'll create health education to guide women, not to scare them. So we're working with people to make sure that, we're not doing a scare factor, but, how to mitigate your exposure to some of these toxicants once we have the data. And of course, once we understand, where the exposures are, we'll aim to write studies to intervene. And if it is pesticides that are really driving this, then how can it's the most unregulated thing. Workers are not taught very well how to manage pesticides. Women don't, their husbands or their partners can come home covered in pesticides. They don't know, the protocol. So we're aiming to probably do interventions looking like that, depending on what the data show us. And so I can talk fast. I'm from New York originally, so I can fly. And I did, but I have an amazing team and wonderful funders all listed here. So I'm glad I have this time to open it up because I'd love to talk more about it.
So good.
Thank you.
Erin?
Yes.
One of the things I was struck with work on Medicaid is the percentage of those women that come back with another pregnancy within 6, 12, and certainly within 18 months. So I'm assuming, not being a clinician though, that the cardiometabolic characteristics would carry into the next pregnancy. Are you incorporating any information about how they can get family planning or types of family planning or what their plans are, and letting them know that this would carry into the next pregnancy?
Yeah, that's a great, do I need to repeat it or could everybody hear that?
Everybody should be able to hear
Okay,
it.
because the microphones are.
Yes, all over the room.
Okay. So yeah, thinking about interconception care and the next pregnancy, we know certainly women who've had gestational hypertension, preeclampsia, we know they're at, significant risk. We, in the peer support groups, we kind of let the women drive the topics. Okay. So if the need for family planning or, birth control comes up, we do talk about that and where to get care. It hasn't been a big topic of concern. Most women come on, they're like, yeah, I'm done. Like, I'm done with it. So that's been the majority of our moms so far.
So far.
Yeah.
Okay.
But it's really important. Yeah.
Oh, yes.
And that fourth trimester and the coordinated care and the postnatal timeframe is just really.
Yes, yes. And of course, citizenship is a requirement, but I was struck by our own data where we have 60,000 in our family planning waiver in Georgia. It's a big program.
Yeah.
Hi, I'm Angie Bankson. I'm a faculty member in the Epidemic department. I do a lot of related work more in global settings and in HIV affected populations. So thanks so much for your talk. This was so interesting. One of the things we've been doing in my team is thinking about gestational weight gain and postpartum weight loss for HIV affected populations in South Africa using peer support models. And I see some corollaries with your migrant population. Just wondering if you could talk a little bit more about how you're actually setting up the peer support groups, like where do you do them? How are you recruiting the women? And a little bit about like who facilitates them in their training.
Yeah, that's a great question. So what I'm learning the hard way is it's really hard to manage a study from Atlanta when it's happening 4 hours south of you. So I can imagine doing global work. So we do have our 2 community health workers. So Lisa and Teresa, whom you saw, they are residents of Colquitt County. They live there. Okay. And so, that was really important to have people, on site. And then working with our employer partner, that was huge. We needed the employer buy-in. I mean, when we're there on the Farmworker program, we're guests of every farm owner. So we're there at their permission. And so when we thought about doing this, we knew we needed that strong partnership at the employer level as well. And Courtney was very, and so she's allowing us to recruit from the work site. Okay. And work with the team lead. They have team leads for their different groups to work with the team leads. So Lisa and Teresa will be meeting with the heads of each work group, talking about the importance of this, that we're not going to interfere with the work schedule, and really get their buy-in and get their ideas for how this is going to work best. I mean, we're doing it kind of organically. We have an idea, to do it, monthly in 60 to 75 minutes. where, we're still trying to identify. We think it'll be at the work site, but then
It's in person.
it's in person.
Yeah, okay.
But then we were thinking, well, work site, you know, if they have work issues, would that be okay? So we're kind of feeling our way on this right now.
Are most people do they live pretty close to the work site?
Yeah.
They do,
Yeah.
okay.
Yeah, so the H2A workers are brought in by the employer themselves. And so the employer is responsible for housing and transportation.
Okay.
So most of the workers live right on site or within close vicinity.
Okay, and sorry, just one more
No,
follow-up question. So do you have, like, what happens if clinical concerns come up? I realize it's a peer support group, but do you have connections to clinical care, or how do you navigate that?
Yes, that was a very important point for us. So Lisa and Teresa both have worked at the Ellington Clinic prior, so they have that direct relationship with the clinic. So anything that comes up, we can make a referral to the clinic. If women don't want to seek care at the clinic, which we've heard that that's an issue, that we have other resources in the local area. And then Dr. Ursula Kelly, who's my MPI, she's a psych mental health nurse practitioner. So for anything mental health related, because we're doing a big focus on mental health and of course cardiovascular risk. So she's the mental health expert, I'm the cardiovascular person. So, you know, if things come up, yes, we absolutely have that clinical resource and referral system.
Thank you so much.
I'll just jump in. This is Ursula Kelly. I'm online. Erin, I just caught the tail end of Hermanas. Hi, everybody. I'm sorry I'm invisible and late. But we are doing really robust training with the community health workers around mental health first aid and you know, crisis intervention. But because it's a clinical trial, we'll have a call system. I mean, the idea will be to refer people to appropriate resources, but in our wildest dreams, Erin and I wouldn't leave the workers down there trying to figure out how to navigate that themselves. So in addition to myself, we have other team members with the expertise to respond. And Erin and I have been developing really close linkages with providers in the community, which is great.
Any questions from online?
I'll add a question, a comment really.
Yes, please.
I'm excited to see the results on, you know, the peer support and just having finished a bunch of focus groups for our Georgia Title V needs assessment with different populations, including the parents of children with special healthcare needs. Like the amount of I need more connection with my parents. I need more connection with other parents who can understand my situation just was coming up over and over again. And sort of to add a personal detail, I would say all the time, I'm the mother I am today because of my mom's group that was run by a local community center, you know, you just show up, meet other strangers, but in that stage. And so I just do think it's powerful. And I'm not sure what the mechanisms are to make it more widespread, but I think, and I don't know if it's declined or if there's a different need, but it's something that I hear a lot across the work. And I personally also believe is very powerful.
Thank you. I do too. I mean, anecdotal, I know is anecdotal, but I'm PhD prepared, well-resourced, and I remember having my third child and I was like, wow, this is so isolating. Like you're home breastfeeding and everybody's out in the world doing their stuff and it's just so isolating. And I remember thinking that, and he's now 16, so I was thinking this, 16 years ago. And it was the same thing I was hearing from my moms. They're like, they have multiple children, they have a newborn, it's really hard to get out of the house, it's really hard to, they feel very alone, they don't know how to navigate things, especially our farm worker women, be eager to see how that goes. But one of our peer support groups, one of the moms just needed help navigating special needs and education services for her child who had autism. And so all the moms jumped in and talked about how to, work with your school counselor and all that. And we just let them go for it. We were just listening. So I think we're supposed to be talking about healthy eating. We talk about, so we let them drive it. So because if she can't focus on anything else if she's worried about her child. So yeah. I do think it's powerful how you measure it, how you get it out there. We're trying to figure that out. Oh, good. All right. Well, thank you, everybody.